Welcome, everyone. This is the Incarceration Prevention and Reduction Task Force Crisis Stabilization Facility Subcommittee meeting. We are meeting on the 19th of October, and I'd like to start with the land acknowledgement, if I might. Before we begin, we acknowledge that we are gathered in the traditional and unceded territory of the Lummi, Nooksack, Samish, and Semiahmoo people who have cared for and tended this land since time immemorial. Truth and acknowledgement are critical to building mutual respect and connection across all barriers of heritage and difference. We begin this effort to acknowledge what has been buried by honoring the truth. We pay respect to their elders, past and present. Please take a moment to consider the many legacies of violence, displacement, migration, and settlement that bring us together here today. And please join us in uncovering such truths at any and all public events. Well, again, welcome. This is the quarterly subcommittee meeting for the Crisis Stabilization Facility. And I think that I'll start with, if I can, Jill, I believe that I can share my screen when you have the agenda down, correct?
Correct.
Yeah,
It should be down.
looks like it. Thank you. Can folks see that? Or did I accomplish getting the spreadsheet up? I can't tell. I don't think so, huh? Let me try that again.
We can see it, Perry, or I can see this.
Yeah, Jack, you good? You can see the spreadsheet?
In a little bit.
Okay, I can zoom in. And folks can also slide the pictures over. Don't know if folks knew they had control of that, but there's actually a bar to slide over. This over zooms it on my screen, but I want to make sure that folks can see that. That's about as large as I can make it and still see it on my screen. Is that okay? All right, well, let me actually begin by just kind of describing this. This is a pretty busy spreadsheet, so my apologies. I'm essentially saving data that is provided to me by Pioneer Human Services and Compass Health, our providers at the facility. If you take a look at this top section, they almost look like duplicates, but this top section is actually Pioneer Human Services data for detox, and the bottom section is Compass Health, that is mental health triage. It is for 2023. This is reflecting quarter one, and we have quarter two, quarter three, that's just reflected in the gray. Each of the different colors reflects the quarters to make it stand out just a little bit more. Quarter one, quarter two, quarter three, and then a total at the bottom. And so that's a duplicate of the data, here on the bottom. So what it's showing us is the program bed days are essentially a mathematical equation for just the number of days that are in the month or in the year. And so for this quarter, there just happened to be 1,456 days. So we also look at utilized bed days. Briefly, that is people in beds at midnight. And you can see that the utilized bed days, so there's a division between those two numbers, and this is how we come up with the percentage. So the utilized bed days in quarter one for Pioneer Human Services detox was 78%, quarter two was 80%, and our most recent data is a 74% bed utilization for a total so far in the 3 quarters of a 79% bed utilization. Unduplicated serves, sometimes individuals return to the facility, and so they count that process just to ensure new individuals served or unduplicated individuals served, instead of counting an individual twice. There was a total of 742 referrals received from a variety, and we'll talk about that: law enforcement, lead, grace, etc. In quarter one, 637 in quarter two, and a duplicate in quarter three of quarter two at 637 that were received so far. 2016 referrals have been received by our detox services in 2023. 8 of those, let's see, I won't run down through all of it because I know that folks can track this and so forth. So I'll just kind of talk about the Q3 and totals. There was an increase actually in law enforcement referrals for Q3. That was 12 in total. We didn't have any EMS. I'll touch base on that. Lead referred 2 individuals to detox. Grace referred 3. MCOT referred 1. Peace Health is one of our larger referrants, referred 66. The jail referred nobody. The reason that we actually include the jail is that at times individuals will be leaving the jail in transition to possibly inpatient substance use disorder services, and the crisis stabilization services facility is a safe place to be if there's a time period in between that individual admitting to the inpatient facility. That's a really common arrangement that occurs. Other professionals referred 101. For a total of 315 thus far in this year. Self and family referred 449, and base camp referred a total of 3 during this Q3, and a total of 27 thus far this year. Again, I know you're now familiarizing yourself with the spreadsheet a little bit, and so I'll drop down. This is, of course, Compass Health numbers in terms of information and data. Same number, of course, of program days, bed utilization, and I'm going to go to Q3, was 57% in this quarter, a bit of a drop from the Q2 and the Q1. I don't have a specific reason that has occurred. Unduplicated served, of course, for Q3 and in total. Also referrals received, and this may be part of the utilization drop. There was somewhat of a drop in referrals for Q3 in comparison to Q2. I am pleased to see law enforcement drop-offs increasing for the triage portion of our program, total of 34, and obviously you see 12 that had occurred in the Q3. EMS, not a lot of EMS activity, but we have a total of 8 so far this year. Lead has referred 5. Grace has referred 4, although none in this Q3. Mobile Crisis Outreach Team, that is our designated crisis responders that go out in the community and work with individuals in both a voluntary and involuntary basis for potential involuntary treatment admission. This is not a facility that is able to accept involuntary treatment admission, but the designated crisis responder as part of the MCOT team can do evaluations at the facility. As a matter of fact, it's part of the RCW requirements if the individual presents as potentially a risk to themselves or others. And so there was 9 referrals from the Mobile Crisis Outreach Team with a total of 38 so far this year. Peace Health referred 108 individuals, just a bit more than were referred in the Q2, and obviously quite a few more from the Q1 for a total of 297. The jail, and I mentioned that there will be transitions of individuals leaving from the jail, the reentry staff facilitating the individual being transitioned to triage care if the individual is seeking additional services. They can get medication, they can get case management, they can get a number of resources and services here. And so been really pleased with that service that Compass Health has provided to the community. All of their professionals, 82 this last quarter, 232 total. Self and family, oftentimes pretty large, referent, of course, 173 for the Q3, 574 total. And then base camp, I think that those numbers also are increasing, and we see, a usage of 16 and 33 for a total. One of the things that we might also look at, if you will, at least these are the things that stand out for me, thus far, a 79% bed utilization for Pioneer Human Services in so far in the 3 quarters, so kind of knowing, and a 68%. And now, hold on to your seats. I'm going to scoot us up to 2022 just to take a look at, those changes. And what we see is a 77%. So a bit of an increase. Sorry, here I go again. 79% now and 77% for a full year. So we don't know what the fourth quarter will bring. And Compass Health had a 56% bed utilization, and thus far they have a 68%. So we're seeing some improvements there, at least from my perspective, and I'll talk about why I think some of those improvements are occurring. I'll stop there. That was a lot of information. Certainly will answer questions, etc. if you want to see, other comparisons between 2022 and 2023. But happy to talk further about this if we want to.
Terry,
Okay.
one question I have is looking just the most recent quarter in both. So that would be July, September 2023, both for the detox and mental health stabilization. So when we see, let's just go to detox, that one. So when we see 74% utilized bed days, what does that translate in terms of if there's a bed? What I mean by that is I understand people come and go very dynamically.
Sure.
The one bit of data that I think would be useful that I don't know how to discern from this is roughly what percentage of the time if law enforcement or whoever contacts the facility and says, do you have a bed, is the answer yes? Does this mean 75% of the time it's full, so it's 1 out of 4 times, or is it actually much broader than that?
Boy, that is a great question, Jack. I don't know that I can answer that in the way that you're asking it, and it's a really good way to ask it. One of the things that I can say is that Pioneer Human Services has taken it upon themselves to email the current bed availability, et cetera, on a daily basis. And we actually broadcast that out, not to law enforcement specifically, but to case managers, et cetera, that we've just begun to create a distribution list for that. And so I'm sorry, I can't really speak to, well, what does that mean of how many days that it's full? And that is actually a pretty interesting question, and would be helpful information to have, or near full, or maybe even tracking how, what's the bed count on a daily basis.
Well, in a different forum, if we were looking at it strictly from public, behavioral health, I might ask a different question. But here, as we're looking at incarceration reduction through this lens, and I know that obviously one of the original goals is for you look good in the tie dye, but for the sheriff and others to have access through this lens, what I'm really interested in part, is how often can they get people there? What's the availability? And obviously simpler is better. The more we can make it available to law enforcement, the better the chances are, I think, that it can be used in that way. So I understand you don't have the data. If there's a way that, and maybe not every day. I mean, even a broad brush is good. Like we can say, about a third of the time, or what. I mean, and you may not be able to, but I think that information would be. It looks like. What do I can't. Under Sheriff Chadwick. But it looks like Under Sheriff Chadwick's going to speak in a moment. But yeah, I think, and he can speak better than I can. But I think them having that data could be helpful in using the facility. So thanks.
Yeah, the thought strikes me that we might ask how many days were 16. Was the bed capacity at 16? Because that's going to give us, a pretty important number. How many days out of the quarter, or how many days out of the month? So I appreciate that, Jack. Thanks for the question.
On the one hand, I want it full. On the other hand, I want law enforcement to have access.
I understand. Absolutely. It's a double-edged sword to a certain extent. Under Sheriff Chadwick.
Yeah, this kind of leads into what Jack is getting to. I'm just kind of curious, like we do in the jail, what's the average bed stay? Is somebody there for 5 days? Or are they there just overnight and then they're referred somewhere else? Or are they there for 30 days? Because 16 beds, if they're there for half the month, doesn't afford a lot of other opportunity for people to utilize the facility and the services. So that's really what I'm getting at. And then also I see the total number of referrals. So to Jack's question, how many actual intakes were taken in? And if they weren't, where are they being referred to? What other services? I mean, that's a very large number of just self and family referrals, people that want the services. So if that's not available, where are we? And I know we're working on that and increasing the capacity, but those are some of the thoughts I have based on these numbers.
Yeah, no, I totally appreciate that. And of course, we're coming up on 2024, God willing, and the river don't rise. And it's a really good time to add some, columns for data. In my mind, anyway, I struggle with the concept of here, let's start adding this in, whatever, February, because it doesn't give us the full picture. So it gives me also some opportunities to take a look at what should we include or be able to draw from, because I think some of this information is there. I know in communicating and working with both of the providers at the facility, I can certainly say that the average length of stay, and it's driven by a number of different things. Certainly the individual getting stabilized is about 4 to 5 days. Insurance rarely covers beyond 5 days because of the level of care, et cetera. So just a clarification. I know that you were, sort of saying, hey, yeah, I mean, is it 1? Is it 20? What is it? That is a dynamic that I can talk about. But I'm making notes just in terms of, because I've been reflecting on how can I maybe make this, information more digestible and more usable for us. So I appreciate that, Under Sheriff Chadwick.
Yeah, like I said, if it's 5 days, I mean, that means a bed's turning over almost, a little earlier than once a week. So that's making it more available. And my concern all along has been when law enforcement shows up, that when they present somebody that meets the criteria, that they're accepted. Because if they're turned away, one, if there's not a bed, or if the criteria doesn't allow that, they're not even going to utilize that as a resource and an option. They'll likely go straight to the hospital or other options.
Right. Understood. And as well, we've certainly touched base on the length of time that law enforcement spends at the facility in terms of that drop off. And I do want to touch base on that a little bit of some dynamics and components that have been happening over the last, quarter and more in terms of addressing that. Thanks.
Great. Thank you.
Ms. Crothers.
Hey, thanks, Perry. Just a real quick comment on what Jack was saying. So, one of the things that we do track in terms of the crisis system related to who does or doesn't end up in a bed. So, we end up calling that a no bed report or walkaways. This is where someone is found eligible for a crisis bed by the designated crisis responders, but for whatever reason, a bed is unavailable, it's not found. And so that is a data point that we track, and just wondering if there's a similar parallel way in which, this system could also track that, kind of what the reasons were for someone not ending up in a bed once they're, sort of do an initial assessment or what have you.
Right. And it's absolutely a great point. I appreciate that, because denials for admission and then getting into that detail of the reason for the denial, if it's not, at capacity and that sort of thing, is something that we do need to gather and that we aren't gathering effectively at this point in time. And one of the goals that I have as far as our 2024 data that we're collecting. So thank you, Linda. I appreciate that. Again, I can't see everybody's screen. So if there are hands up that I haven't called on, please sound out. We'll make sure and touch base on that. All right. I'm going to stop. Let's see. I think. Yeah, I'm gonna stop sharing this. I've got some other documents that I want to be able to share as well, and kind of just running down through my list here of the sort of topics, here on our agenda. Let me see, let me make sure that I made some notes, just increase in bed, detox average. Yeah, and I guess that it was, somewhat familiar. I should have actually touched base on this before I took it down, but our law enforcement use of the Crisis Stabilization Center in 2022 um, was a total of 75, which is an average of 19 per quarter. Again, those are referrals that had occurred, and admits that had occurred. And our law enforcement use of the Crisis Stabilization Center for this 3 quarters of 2023 is a total of 63, which is 21 per quarter. So we're seeing again an increase, and I will talk in kind of the next topic about some action steps that I have taken and am planning on taking relative to law enforcement drop off as well. So the next topic is our behavioral health drop off and transportation, and that challenge. Let's see. Let me make sure. Yeah, behavioral health drop off and transportation at the Crisis Stabilization Center. And what we're making reference to here is let me sort of describe a dynamic that I think has been going on that we're targeting. One of the factors related to the drop-off time for law enforcement first responders is that the providers, Compass Health, Pioneer Human Services, ascertaining admission for the client as the law enforcement professionals, and et cetera, are there. Additionally, and I think that this is even more important, the providers are viewing, in the event that the patient is not eligible for admission for some reason, let's just, there are some reasons that obviously come up, that the provider views law enforcement or the first responder as a transportation for the client. In other words, in sort of their framework, it's like, well, you brought this person, let's see if they're, eligible. Oh, they're not. So thank you so much for attempting. See you later. Take your, person with you kind of thought process. And again, this isn't something that I've gotten from interviewing or anything else, but it's like, well, what I do know is for the providers at the Crisis Stabilization Center, they have not had an option for transportation for individuals. And so that's that naturally occurring just sort of, perspective that law enforcement brought them so law enforcement can take them to wherever they need to be, whether that might be the hospital or base camp or, or what have you. So keeping that dynamic in mind, the action steps that the providers along with myself have taken is, I think that folks will recall that we streamlined the protocol for specifically law enforcement and first responder drop off. And what that really consists of, and I'm going to go into even a little more detail on this, is that the law enforcement first responder can place a screening call. That's a very specific term that I'm using, to the facility, which is unique for law enforcement, and actually confirm that there's a bed available. So they can pick up the phone and they can call and they can say, hey, Pioneer Human Services, is there a bed available? Yes or no? Because that's, of course, what they actually need to know, as we were kind of talking about before. Yes, we have a bed available, is the protocol for that. It also allows for the provider, whether again Compass Health or Pioneer Human Services, to ask some basic screening questions. There are some disqualifiers relative to the provider's certification. And again, I'll talk about this in another component of our discussion, a little more detail, but essentially the questions that are asked are the individual's BAC level, if that's available, whether or not the person is oxygen dependent, that is, if they're on, oxygen or an oxygen tank, if they're able to perform activities of daily living, it's a basic, concept of are they mobile, can they take basic care of themselves, is the individual a level 3 sex offender, which is not a disqualifier, but the providers have to make some arrangements if the individual is, and is the individual combative or threatening. because, and again, I constantly reiterate this, that the staff can't go hands-on. Assuming that those, it's like, nope, you know, they're not oxygen dependent, they're mobile, you know, there's no level 3 sex offender, you know, background, they're not combative, they're open to, you know, coming, they're going to hold the bed, then the facility holds the bed for transport. So we're informing the law enforcement, you know, first responder, that it's like, okay, we're holding a bed, we'll look for you, you know, at this point. So that's a very important aspect of this, in my opinion. So what I just described for you, and I can show you really quickly, let me make sure I've got it here. I printed up some law enforcement first responder visor cards, and this side over here is, you know, as it says, it's just, you know, it's just a quick reference, you know, ability with, you know, obviously the phone numbers and you know, and so forth, and walks the law enforcement first responder personnel through the steps that I just described. So we've printed 300 of these, and I have distributed these to the law enforcement offices within Whatcom County, and just sort of circle back and touch base with to make sure that they got there. So literally for that, you know, officer or deputy that's boots on the ground, phone number, here's the extension, this is what they're going to ask you, and you know, the goal being that I can confirm that there is an available bed before I spend the time, you know, transporting an individual there. And this is a protocol and procedure that's been established with the staff at the facility. So I wanted to show that as well. I don't know if there are any comments or questions. I'll take it back down just so I can see everybody.
I got a question.
Please, Todd.
I'm sorry, I've been the other side of attendees here. So what happens if somebody is above 0.25? Can they be admitted?
You know what about that, there's, and it's a, you know, it's a little more, you know, detailed than I wish was true. 0.25 is the ceiling for mental health triage and their ability to work with that individual for mental health stabilization. But there is a 0.35 level for detox, because of course they're more oriented towards that. So a couple of things can happen. I mean, depending on the individual and what BAC level, you know, they happen to be at, the individual could be admitted to the detox portion of the facility, and the two providers do have a memo of understanding and working with each other. Obviously, they're located, you know, very close to each other, so they're communicating and looking at an admission on the other side if it is 0.35 or below. If higher, then it does necessitate a medical, you know, review at the emergency room. One of the concerns, and you know, just continue to have, you know, discussions, that individual may have other substances that they've ingested besides alcohol, and so, you know, just concern that for the individual's safety and so forth. So that's what would happen.
So if they show up at the Compass Health side at 0.25, or then they would be referred next door?
They're literally walked. I mean, it's not even honestly next door. It's really the same common area, and maybe you've been out there, but it's like, hey, let's walk over, let's communicate with the admitting nurse, you know, that's at you know, detox and so forth, and you know, and address this individual's needs. That is the protocol and procedure.
Or I thought there's also drop off in the back, or is it everybody just comes in the front?
You are correct. The design of the building was for law enforcement and first responder drop off at the rear of the building. And the way that the facility is set up is that there's an intake room, bathroom, you know, sort of area and location there. Because, you know, coming in the front, maybe, you know, depending on kind of what's going on, maybe, you know, disruptive for the individual. And for first responders, the bays were built so that they could literally back in and just, you know, have immediate access. So that is true. So I'll, oh, anybody else in regards to the visor cards? I did want to share, let me make sure that I'm not wandering off on my notes here. Yeah, I'll talk about that next. So still, kind of on this behavioral health drop off, first responders, that sort of thing. So those were the actions that have been taken so far to continue to improve law enforcement and first responder drop off. The actions that I also have planned, I wanted to make reference to them. um, Thankfully, the Response Systems Division within Whatcom County Health and Community Services has recently hired the term that we're using for the individual is a behavioral health aide, but essentially is a driver. And the van that EMS donated to the health department, we're utilizing that van to transport individuals in the community, vulnerable individuals in the community that need some form of transportation to, an appointment or whatever it happens to be. So this young man, his name's Colin, that is our behavioral health aide, is available within the community Monday through Friday from 9 o'clock to 5 o'clock. And so I'm communicating with, and we'll formalize this more with Pioneer Human Services and Compass Health, that this is an available transportation for them. They can literally call him, he can go out. They don't have to worry about law enforcement or first responders sticking around to transport the individual if needed. They can call on this particular resource. It is limited to there's medical transportation. Obviously, requires ambulance, or the first responder in that given situation. But hopefully, our communication with first responders and law enforcement is such that that won't be necessary. And typically the providers will use Cascade Ambulance for that kind of transportation. Another action step that I'm taking through conversation with my supervisor, Melora Christensen, is to set up what I'm going to refer to as a flex fund with the two providers that allows them to purchase transportation. I mean, obviously the contract would be written in a very specific way so that they have the ability to purchase transportation, whether that's a taxi or, or what have you, depending on the individual, so that the cost of transporting the individual doesn't come out of, of course, their funds, because we don't have a contract with their providers that would be more of like a traditional contract that would include a flex fund. So again, saying, listen, the goal here is that we want to give you an option for transportation. You can set that up with Uber or again, taxi, etc. And the cost is paid, through your contract. Therefore, no reason to hold on to law enforcement to transport an individual that for one reason or another is not an appropriate admission for the facility. Lastly, the planned action that I am going to take is we looked at our visor cards. I'm actually meeting with Bellingham Police Department and having an opportunity to talk with the sergeants as well as other individuals in the agency and walk through the double-sided card that I showed. One is just general information about the Crisis Stabilization Center, and the other one being that specific process that law enforcement can use. And I've got that set up for early in November. I've also been communicating with Chief Donnell Tanksley relative to Blaine and some of the other small cities law enforcement, to communicate with them about utilization of that, and also this sort of direct line for law enforcement, if you will. So I just wanted to outline the actions that are planned relative to this challenge of law enforcement and the time that they have down and being out of patrol when they are dropping off somebody. I've really kind of had the discussion and come to the conclusion that law enforcement professionals may be able to provide a certain amount of information to the Crisis Stabilization Center providers, but probably not a lot relative to the needs the individual has, certainly not beyond what they can gather from an intake and an admission process. So again, no real need to hold law enforcement. Thoughts, comments, questions about that so far? All right. Our next topic that was that's on the agenda is 12-hour holds. I'll give just a brief summary of this. We've talked about this a fair amount, and I think that looks to me like everybody here is probably pretty familiar. The 12-hour hold option with specifically Compass Health, and I want to underline that this is not true for Pioneer Human Services Detox, but this is true for Compass Health. Is actually outlined in RCW 1031-110. And what it does, just generally, is that it allows for law enforcement to place a 12-hour hold on an individual that's committed a low-level crime. That is an option for the law enforcement personnel to transport the individual to the Crisis Stabilization Center, essentially have a discussion with them, placing and informing them that they're on a 12-hour hold. And one of the steps that has occurred to make this available is that Compass Health has completed certification and hired additional staff required by this RCW 1031-110 in order to provide that service. Again, our Crisis Stabilization Center is certified as a residential treatment facility. They refer to it as an RTF. It is voluntary services, and the staff can't go hands-on with a client. They can certainly work with an individual, and oftentimes do, that says, I don't want to be here. I want to leave. And it's like, well, hey, let's talk for just a minute. There's always time to leave and have a discussion with the individual, get them some food. I think as folks are aware that there are essentially private rooms in the facility. And so, offering those opportunities and using motivational interviewing to to get the individual to accept the support that's being offered in that given situation. We have not had any 12-hour holds implemented to date. I met with Eric Ritchie, Jason Gum from the Whatcom County Sheriff's Office to discuss the opportunity for 12-hour law enforcement holds, and provided obviously information to relative to the RCW and so forth, and just confirming that it's available, the facility is licensed for this, etc. And as I met with the prosecutor's office, there was concern about the RCW and the way that it was written. Again, this is my interpretation and understanding of the meeting and the discussion. The prosecutor's office forwarded the RCW to our county attorneys to have a review on that because of the fact that it's not a locked facility. And law enforcement is taking an individual there that has committed a low-level crime. So the inability to secure the individual, which is absolutely accurate, that was passed along to our senior deputy county prosecuting attorney, reviewed the statute and essentially made a recommendation and I'll just say to stand by relative to utilization of 12-hour holds. I was informed by the attorney that his client understandably was the Whatcom County Sheriff's Office, that there was communication that was being was going back and forth there. He wasn't able to share with me the specific nature of those recommendations and etc. By virtue of the fact that there was an attorney-client privilege. And so that's where that process ended for me. Certainly does not indicate that the process ended for obviously the attorney, the county attorney, or Whatcom County Sheriff's Office. But I did want to speak to that I am also reaching out to the city attorney for Bellingham to have the same conversation relative to forwarded him the information about the RCW and etc. As we're seeing in the data, law enforcement is most certainly using the Crisis Stabilization Center, not to suggest that that's for 12-hour holds, but wanted to be able to get that information out, be able to obviously communicate with the city attorney. The RCW does specify that the prosecuting attorney's office needs to be involved in essentially ascertaining which crimes are appropriate and inappropriate. But the RCW also does speak to the fact that the law enforcement enforcement professional cannot be held culpable, but there were certainly concerns relative to the strength of the RCW statement in that regard, and I suspect that that's part of what's happening in terms of the discussion between the county attorney and the sheriff's office. So wanted to update folks in that regard. Thoughts, comments, questions? All right, moving along. One of the things that came up, and this was a quarter ago, but one of the things that came up was just sort of a topic of lease contracts and vendors versus service agreements. I don't honestly recall what the specifics about this topic, this discussion topic was, but I can speak generally to it. And again, if there are questions, more than happy to attempt to answer those. We have lease agreements with both Pioneer Human Services and Encompass Health, obviously, and essentially what those lease contracts, I mean, they're fairly, extensive contracts, but what the lease agreements provide is that both Pioneer Human Services and Encompass Health pay $2,000 per month for utilization of the facility. That's $2,000 each, and also that the providers assume the cost of utilities. So the county is responsible for maintenance and upkeep, and and some of those things, and that's essentially along with the other legalities of a lease agreement, what those lease agreements accomplish. I also back in 2002, just right at 2000, started 2001, wrote memos of understanding, language that is actually linked to the lease agreement for both Pioneer Human Services and Compass Health. And the reason for this is because, and I think that everybody's cognizant of this, but the reason for it is that we don't pay the fees for crisis stabilization to the providers. That is paid through Medicaid and in part also paid through the BHASO if an individual is not insured or for some reason the insurance won't cover. And and so we also wanted to be very clear as we were opening the Crisis Stabilization Center, what the expectation of the county was relative to a memo of understanding in regard to services being provided. So it was a bit of a balance in the sense that we're not paying for services, so we can't dictate that, if you will, beyond RCW and WAC requirements, which is actually referenced in the MOU. But we also wanted to be involved in, and so part of some of the requirements, for example, in the MOU are attendance at the Crisis Stabilization Center Advisory Committee, providing data, and those sorts of things. So wanted to just speak to that generally, and I see Under Sheriff Chadwick, you have a question.
Yeah, sorry, I was finishing up a sidebar conversation here when you were talking about the 12-hour hold. So I understand there's some concern for that. And again, from a law enforcement perspective, it's still viewed as a voluntary facility, not understanding that the staff there at the Crisis Stabilization Center can't keep somebody there. So if somebody is, we're concerned about their safety, we're not looking at that as an involuntary facility, even though that they meet that certification standard.
Absolutely understood. And that's, I think as far as from my perspective anyway, continuing to communicate, to work with, to be available, in that regard. Yeah. Councilmember Donovan.
Following up on that, we had a discussion when we were designing this to make it intentionally have the capacity for involuntary holds. So it's built that way. So what's holding that back?
And so my perspective, and again, Under Sheriff Chadwick, not speaking for the, law enforcement or for the sheriff's office, the 12-hour hold, to get into just a little more detail about it, is there has to be certification and licensing, which I said, was already accomplished with additional staff, which has been accomplished. And an individual is taken there by law enforcement and informed, listen, you are on a law enforcement hold. If you leave, there certainly could be consequences. You need to understand that. And the RCW actually makes reference to the Crisis Stabilization Center staff contacting the law enforcement office. I mean, they keep, of course, the information, the drop off and, and so forth, contacting the law enforcement office if the individual leaves before a 12-hour period is up. And again, to Under Sheriff Chadwick's point, that still does not make it an involuntary facility. It is not designed, locked, et cetera, as an involuntary facility. The billing design, nor is it locked in that way. If an individual chooses to leave, the certification and licensure for both Pioneer Human Services and Compass Health absolutely requires them to first sit down and talk with the individual. But if the individual demands to leave, then they have the right to do so. The only case where this wouldn't be true is if an individual was, and this gets a little gray, but if the individual was a current risk to themselves or others and was meeting criteria for involuntary treatment admission, calling a DCR and having a DCR meet with the individual, again, it gets into a bit of a gray area there as far as can you hold him? And it's like, well, we can, the DCR, actually has some ability with that. And I think that folks are aware that our DCRs are also Compass Health staff. So there's some pretty fair coordination that goes on there. But beyond the fact that there's information taken, that there is a discussion that occurs, that the staff is aware of the fact that the individual's on a 12-hour hold, and if the individual left, that the law enforcement office would be informed in regards to that departure, and that it's all documented. That is about the extent that the staff can take beyond clinical steps and tools that they would take to motivate the individual to remain. So I hope I'm answering your question. Where we are using an we're using a voluntary facility to implement an involuntary process, which is exactly what, and I can send it to you, Councilmember Donovan, if you'd like to look at it, this RCW, it is actually the specific intent, of that. Yeah. Under Sheriff Chadwick.
Yeah, I think what Councilmember Donovan is getting to is exactly the early conversations that I remember even before the facility was built. Is the whole goal was to build a facility that we could utilize for law enforcement to quickly get people the services they need, not utilize and tap the resources of the hospital and the ER, which is what had always been the practice. And it was originally, the discussion was it was going to be an involuntary facility. And I don't know if you recall, I brought up early on that I had some concerns about the staff there, just because people in mental health crisis may be calm 1 minute and things change very quickly. And I know some rooms were built to, one, protect the person and protect the staff. So I think that's the frustration where we're at right now is that's how it was originally conceptualized, and that's not what's happening. And that's not best serving the people in crisis. It's not best serving the community. Law enforcement can't use it that way. So that's the frustration right now. And that's why I don't think a lot of law enforcement are using it. And I understand a DCR, they can make the determination to take somebody into protective custody. And our concern, if bringing somebody there on a 12-hour hold, we need to know that they're not likely a flight risk to leave there and do harm to themselves just outside that facility.
Yep. Yeah, Jack?
Just a little institutional memory. I do recall this topic at length, and actually, and not to correct anyone, really early on, there was no discussion about involuntary. And then Ann came to us and said, look, there is this statute. We believe this is appropriate. We're not saying we have to do it, but we believe the facility should be set up to do it. We then took that to the full task force for a discussion, and the task force endorsed the 12-hour hold, because we weren't quite, we felt, since it had originally been presented not being along those lines, we were very careful to parse the substance abuse disorder side from the mental health side. But definitely, my memory is pretty clear on this, that there was that discussion, that Ann brought it. And I understand there may be some execution challenges now. I'm not disputing that, but I do know that the task force approved it. That was the intention, and all of it is, well, under Sheriff Chadwick and Councilman Donovan said, was very much, I mean, the mantra I always remember was 10-minute drop off. I'm not saying that's realistic, but that's what we were saying over and over and over. Because going back through the lens of incarceration prevention, which is what this group focuses on Crisis Stabilization Center for, we knew it had to be quick. We knew it had to be simple. Even things like the ports in the back where they could bring people in, theoretically, were all designed to make that that facilitation possible.
Yeah, I remember we talked about actually redesigning the facility to make
We did.
this.
We made changes in the facility physically to accommodate the desire to accomplish that. Absolutely.
Mike, while you're on all these sirens I'm hearing, that's some kind of drill.
It's
That's
me,
the
Sandy Point.
earthquake drill. Yeah, the tsunami.
Oh, you got them too? I'm at Sandy Point and our giant siren, you know, the big tsunami one's going.
Yeah, that's going a long time. But anyway, so I guess that, you know, what do we do to make it work for law enforcement? Or is Perry saying the way the law is written, it's not what we were actually expecting the involuntary capabilities to be?
You know, a couple of things that I'll share. You know, level of care. You know, again, as I had described, this is a residential treatment facility, certified level of care, and the design of the building itself, literally the way that it's set up, the locking mechanisms, and et cetera, is designed for a voluntary setting. There is, as you know, we've made reference. There is actually a boy, what do I call it? There is a location at the back of the facility on both sides that has a safety room, that is a padded facility that is, you know, allows observation of an individual. There's a restroom that's right there, et cetera. And my recollection anyway, and you know, recommendations as I was pretty early on in terms of my involvement with the IPRTF at that point in time, was that this should be a consideration while we're building this, because there may be a need, you know, for this kind of being able to go hands-on, you know, if an individual is at risk to themselves, you know, and et cetera, et cetera. And so way cheaper to build that process in than it is to go back and remodel that process of, you know, kind of consideration. And so my understanding, and I think I could probably get confirmation of this, you know, from architect, you know, et cetera, is that they're really, without, you know, an very involved retrofit, there is no way for our currently existing crisis stabilization center to be a level of care of involuntary. The next level up on involuntary is referred to a evaluation and treatment center, or, you know, the quick version is an ENT. There are, you know, several ENTs in the North Sound region, you know, through the 5-county region, and they are designed and staffed in a very different manner than the you know, the voluntary facilities are. So I'll just sort of, you know, share that piece of information. I think that a lot of times in discussions that I've certainly listened to and been a part of in various meetings is, well, we need, you know, an involuntary facility, which is fine. You know, that's not necessarily for me to determine. There is a fairly short length of stay in involuntary facilities, you know, by statute, for involuntary treatment admission, you know, et cetera. So I don't know that that would, it certainly would help to have that immediately available, but it is not a long term. There is no such thing other than Western State Hospital and Eastern State Hospital, and I think we're pretty familiar with kind of the dynamics that are going on there. The ENTs are, you know, typically, boy, I'd have to guess because I'm not super familiar, but I'd say 10 to 12 days, maybe 14-day stays are sort of the maximum of that, where the individual is stabilized and, you know, and et cetera. So certainly not my area of expertise, so I don't mean to, you know, climb into that. So, you know, again, one of my steps, this action step in regard to utilization of 12-hour law enforcement holds, it hasn't occurred yet. If an individual, and, you know, my thought process, and I'm sure it's oversimplified, my thought process is, well, then the prosecutor's office could significantly reduce the criteria or if you will, the charge that would be allowable to utilize the 12-hour law enforcement holds to nonviolent, whatever. And again, I'm probably oversimplifying, to reduce the liability for the county or for the law enforcement, individuals. That it's like, listen, is this an individual? And I know that this is sort of taking just a moment in time and a consideration that, if I understand correctly, individuals that we're talking about, the level of crime that they would have committed probably wouldn't be taken and booked into the jail anyway. And so this offers that kind of level. But again, I very much may be speaking out. I know I'm speaking out of my knowledge base, but that's of course changed, since COVID and the other dynamics of what the jail capacity is, and et cetera. And so it makes me wonder if there is an area that, with those types of charges, that it could be considered, whether or not a 12-hour hold. And I think to some extent that may even be what's happening. I have no idea of the law enforcement drop-offs that have occurred, that it's like, listen, we, this is kind of a gray area. We can, we have a certain amount of latitude here. And so we're going to take you out to the Crisis Stabilization Center because you've expressed an interest in going, or something of that nature. And so law enforcement certainly is using it. And I want to do what's best for the county, obviously. Yeah. Under Sheriff Chadwick.
No, you're right, Perry. So it's, lower level crimes, and we have the discretion to even make an arrest or not. But with booking restrictions, a lot of those lower level misdemeanor, gross misdemeanor, and a lot of times they're crimes of poverty. So trespass, shoplifting, things like that we're not going to book into jail anyways. Quite frankly, probably not make an arrest on at this point, and just use the discretion and decide that maybe there's a better place for them to get the help that they need. So I just, like I said, you're not far off on that. So I don't know that the prosecutor really changing the criteria for bringing people into jail. Like I said, as long as it's not a crime of violence and there's some concern for the staff, I think those type of crimes, when the root cause is somebody in mental health or substance use crisis, would be applicable for this facility. It's just are they going to stay there? And that's really for law enforcement, what the kind of decision point is. Do we believe that they're going to stay there and seek help, or are they going to create a risk to the staff and likely walk away? And now we have to be concerned about them somewhere we don't know where they're at, have to locate them and worry about them doing harm to themselves or others. So unfortunately, I have to take off, but I just wanted to get that in before I left.
Thanks for your involvement, Under Sheriff Chadwick. Yeah, I did want to say that something that Doug had brought up in our meetings, the IPRTF meetings, was concern for security at the facility. As we were talking about it and designing it, I remember distinctly us having discussions about that and saying, boy, the potential here. And we weren't necessarily talking about, the 12-hour law enforcement holds per se, but it was just, the concern for the safety of the staff and, and the safety of the clients as well. So that was certainly something that we discussed, and there were recommendations, as I recall, Under Sheriff Chadwick, from you saying, I would really recommend that there was some security, that was in place there. Again, interesting dynamics in terms of the providers, at the facility. There are other crisis stabilization centers in North Sound region, and they don't have security either. The staff are trained in terms of, being able to respond to an individual and et cetera, but that doesn't necessarily take the place for security. So I'm not recommending it. I'm just, making a reference to, part of the discussion that had occurred. Other thoughts, comments, questions on this? Mr. Hilly?
Yeah, thanks. I apologize for being a little bit late. I had an earlier meeting went late, but I echo the undersheriff's concerns. It's been a little disappointing from the EMS perspective that we haven't been able to divert we haven't been able to divert. And there was a big hope, there was a big sort of, that's kind of what we were going to be able to do at that facility early on. And that's referencing the 15-minute drop off for EMS. And while more of it is probably related to the SUD side of the house, there are times when EMS would be able to, transport to the mental health side. And that's suicide ideations. Somebody in the community, maybe out of, in East County, says, hey, I'm off my meds. This is a rough day. I'm scared for myself. I need help. EMS could actually take that person there as well, as opposed to the ED, which is the deal now. So we just haven't really achieved that level of diversion that we had hoped for in those early days of the planning on this. And probably not for discussion today, but there may be some intermediate steps that maybe would help with that in a short-term holding facility if we get that 23-hour crisis stabilization, or 23 hours center up. And as we work in the MAC group, some of the ideas floating up is maybe could there be an opioid receiving place that's just independent that could take those patients in, receive the reports from EMS. Over 50% now are leaving once EMS wakes them up in the street from their overdose. Could we change that narrative and say, hey, you don't need to go to the ED, let's go chill in the lounge over here. Maybe that's where you get a social contact. If you choose to take services that day, then you could go to the stabilization facility, the Deacon Center. So those are some of the things popping up, but I just do want to, and I know it's old, you hear it from me every week or so. We just like to achieve that higher level diversion for EMS.
Well, so Mike, this is a good thing for me to hear about. So it's not that it's not an involuntary facility. Is it the time to drop off? What's the barrier for EMS?
Yeah. Well, and Perry's well aware of this too. It was more complicated to get somebody admitted than I think we thought on those first sort of planning days. So it's an ability to pay. Are they medically stable? Are there other existing conditions going on with that? And back to the drop off point, it was kind of one of the ideas was that you'd come into that back drop off area to a central area. You might have a nurse that would triage that patient, make sure they're medically stable, and to decide which side of the facility that they would go to. But we've had several cases where people called 911 and they were medically stable and perfectly suited for the stabilization facility, but turned away at the door for various reasons that I'm not really sure of why. But yeah, it's definitely not low barrier to get in there at the moment.
I did a tour with a couple of state legislators, fortunately, and the Compass Health folks were talking about how much time it took to admit somebody because of paperwork, the state, not just federal paperwork. And it was good having the legislators there because, I thought we passed a bill to deal with that. So, so I think there's folks at the state level that are trying to. It's nothing that Compass can deal with. It's just there's admissions requirements. I don't know if that's why some people get turned away, but that was a surprising amount of time. Even if it's a quick drop off by law enforcement or EMS, they spend so much time finding insurance, doing the insurance paperwork.
Well, and the other problem, Todd, is that somebody has to navigate that for them, right? So if an EMT says, hey, yeah, I think it'd be great to go over here, that EMT has to call the facility, and they get in this really long conversation about, can you come over? And the EMT really doesn't have not only the time, but really the ability to navigate that. I think our community paramedics could probably navigate that a little bit easier. And I know they've worked in that area, but yeah, there's a long time to wait to make that determination. And we had hoped that'd just be the 15-minute drop off. Somebody else makes that determination. If they can stay, they stay. If not, we get them transportation to another facility or the ED if that's where they need to go.
It's still a learning curve here.
Yeah.
Well, and at least from maybe a bit of a naive perspective, that looking at this transportation alternative, if an individual isn't appropriate for, from the providers, it's their certification, it's their licensure, from the provider's perspective, that it's like, listen, you let EMT, the community paramedic, let them go on their way. They are not the transportation for the individual from this location. They are, our community, doing community service, and arranging for, immediate transportation if that need is there. I'm I'm really oriented towards that and setting those two options up. Where, as I'd mentioned, we can use our behavioral health aid with the van that the EMS had donated to the health department, as well as having a flex fund for, again, a cab. Great. It doesn't matter to me what transportation that they use, because I think that it's costing more to have EMS wait while the individual, to see if the individual can be admitted. It's like, no, that's not necessary. They're not providing any information there. They're literally being viewed, in my opinion, as transportation if the person can't be admitted. So those are some of my thoughts and what I want to push forward with, just in regard to alternatives. Mike's worked really closely with us and spent a lot of time in his communication and efforts to accomplish what he was describing. Seems like a pretty nice guy too. Our next topic, if there aren't additional comments or questions in that regard, there were really twofold. If you look on your agendas, the surveys and online form for the Ann Deacon Center for Hope, for providers, users, law enforcement, EMS. I believe I'm correct in this. I was just recently in a legal injustice. I think it was actually one of our combined legal injustice behavioral health subcommittees for the IPRTF, and there was discussion around surveying EMS, law enforcement, and et cetera, to get to the root problem. Again, I sit in on those meetings for information and so forth. I'm actually a member of the behavioral health subcommittee, and I said, well, I mean, my sense is, and communicating with Mr. Hilly and Under Sheriff, Chadwick, that I have a pretty good sense of what the challenges are. But if a survey is something that the subcommittee wanted to pursue and so forth, that I didn't think that would necessarily hurt. So that's about as much as I can speak to, and the reference of completing a survey and etc. I did want to reiterate, and we've talked about this as well before, but it's a great tool. There is an online form that can be completed if a professional or anybody, for that matter, oftentimes case managers, sometimes the mobile crisis outreach team, our DCRs and etc., can complete. It is on the county website. If you want to happen to take a look at it, you can even put in Crisis Stabilization Center form and it will actually pop up. So we continue to communicate in a variety of meetings that this online form is available. You can fill it out as much as you want or as little as you want in terms of describing concerning or positive events that had occurred with the Crisis Stabilization Center and admission to that facility. What happens when that form is filled out is that it automatically shows, well, it gets stored, but it automatically shows up in my email as well as my supervisor's email, Laura Christensen. I typically will go through those. If there's some additional information that would be helpful on a specific incident, I'll call the person that has submitted the form. I then use that form to communicate with the directors, supervisors of the crisis stabilization services, try and figure out, well, can you talk to me about what happened? Obviously, it gives us some pattern responses. One of the patterns that we have run into in some of the systems improvement forms that have come up is that a intake staff on the phone is unavailable because they're doing an intake at that point in time and can't leave the existing intake that they're completing to sort of phone triage with with an individual. And so that's become a challenge, and obviously it's a staffing challenge. Easy answer is, well, just have the provider hire another nurse for to complete the intakes. Obviously that begins to get into challenges as far as cost and so forth in terms of staffing model. But my point being that the systems improvement forums have really been helpful, because initially what we were getting was maybe some emails or a voicemail message that, hey, I went out there, it didn't work out for me, and so forth, and it really wasn't bringing enough information. It also wasn't really tracking the dynamics that were going on. And so from there, what I've done is, especially as we began to see some patterns develop, the length of time, for community paramedic to remain, or various things, that I may contact again with the director of Compass Health or Pioneer Human Services and talk to them about, I'm less interested in why that happened. I mean, we can have that conversation, but I'm more interested in what we're going to do. So are there actions that you would recommend at this point that we could put into place as a process so that we can respond to? We discuss these in the Crisis Stabilization Center Advisory Committee that meets once per month, and that we can talk more specifically about actions that we feel are important to take, as opposed to, necessarily just simply discussing the reasons that occurred, because the reasons don't necessarily move to a point of what are we going to do about it, and that can also be a perspective of the individual attempting to utilize a facility, or for the providers. So I did want to make reference to that systems improvement form that is online. I get, I guess I would say, maybe an average of 2 to 4 in a typical month. And again, we take them to the monthly meeting. I've actually continued to, I think that folks are aware that the Response Systems Division, GRACE, LEAD, our co-responder program, mental health court, etc., made up of about 39 staff now. Often, many times, these outreach staff are interacting with the Crisis Stabilization Center, and I have encouraged all to, if there's any questions, submit the form. Let me work with this. We need this kind of feedback, and so forth. So I wanted to make reference to the fact that we're utilizing that, and also, of course, make reference to a survey and so forth. And my response to the Legal and Justice ad hoc committee was, I mean, that's certainly your choice. I feel like I have a pretty good sense of it, but would always embrace additional information coming in. One of our, getting towards kind of the end of our list of agenda items is, we talked briefly about the hospital and utilization of the hospital, utilization of the Crisis Stabilization Center for by the hospital for individuals that are coming into the ED, or possibly other situations that are referred to the Crisis Stabilization Center. I can share with you that in 2022, Peace Health transfers to Pioneer Human Services. I'm just reflecting the data without putting it back up, but there was 158 referrals to Pioneer Human Services, 364 to Compass Health for mental health triage. Again, this was in 2022, for a total of 522 referrals to the Crisis Stabilization Center in 2022, which is an average of about 131 per quarter. In 2023, there were, this is just January through September, mind you, there were 157 referrals to Pioneer Human Services by Peace Health, 297 referrals to triage to the Peace Health side, mental health triage side of the facility, for a total of 454 so far. So we're, about at the same. It's a little bit higher. The average per quarter is 151 referrals in 2023 so far. So I don't know that well, I guess I do know, I really couldn't speak to cost saving relative to Peace Health and the referrals. I think for the most part, although I'm communicating with some of the staff there at this point in a particular case of where that referral process wasn't communicated well and there were some challenges, but for the most part, those referrals and that communication between the hospital and the Crisis Stabilization Center are, it's fairly fluid. the staff know each other and so forth, which, and I'm sort of jumping to the next topic, but I think it's going to be extraordinarily important relative to Mike mentioned the 23-hour crisis relief center. At the risk of that being a location of where the hospital would discharge to, which actually the legislative language speaks very specifically to that very thing. I suspect that what happened was other locations in other states where 23-hour crisis relief centers had been developed had experienced some of that individuals were being discharged from the hospital, which of course is not the intent at all. But anyway, again, I'll speak more to that. But that's my information on cost saving for the hospital, unless there are more questions about that particular topic. There are some meetings developing relative to, with the hospital and certainly other entities in the community relative to this 23-hour crisis relief center development. I think everybody's pretty familiar that we got capital funding for that and are taking a look at, you know, design and a number of other aspects to that. So I'm actually a part of that work with the executive's office. Our next to final topic was licensure and licensure options and barriers. I think that we really got into that topic when we were talking about the design of the Crisis Stabilization Center as it is, the certification, you know, with Compass Health. You know, part of my frustration too, you know, not aimed at any, you know, specific entity, just the system, you know, working the system in itself. Compass Health extended some pretty significant time, effort and funding to follow through with this, which actually just I'll make mention to it, getting the certification for 12-hour law enforcement holds. That was part of the memo of understanding that they would take those steps to accomplish that process. So they were familiar with the need to do that, you know, prior to even opening the Ann Deacon Center for Hope. And that's about, I don't know that there's anything else that I can really speak to relative to licensure options and barriers other than to say that I don't believe without significant remodel and cost, the Crisis Stabilization Center could be transferred into a involuntary facility, as I mentioned, commonly referred to as a evaluation and treatment center kind of dynamic. So yeah, I guess I'll stop there, you know, on that one, unless there's thoughts or comments.
I always get confused when these evaluation and treatment centers are called ENTs because it makes me think of ear, nose, and throat doctors.
Yes, yes.
I'm getting there.
I called them ENTs for a long time and went, oh my gosh, I don't think I know what the ENT stands for. You know, for
I'm
sure.
getting there.
Right. So the other thing that I would like to share briefly, let's see, where were we? I think that we were in the steering committee for the Incarceration Prevention Reduction Task Force, and there was discussion about you know, just informing folks relative to the 23-hour crisis relief center. And somebody in their wisdom said, well, that's so similar to the Crisis Stabilization Center, Perry, and you're already sort of on that pathway. So why don't you just go ahead and report on that in your quarterly reports as well? And I, you know, certainly was open to, you know, to that, you know, option. So, hoping that folks, yeah, can see that. This the crisis the 23-hour crisis relief centers was born from legislation in our past, you know, our most recent legislation that's been completed in House Bill 5120, Senate Bill 5120. Again, establishing crisis relief centers in Washington, as you hopefully maybe I can expand this just a little bit. Maybe that's helpful. And so, you know, again, talks about, this is just the final bill report, just a summary of that to give folks just sort of a cross reference. I highlighted some of the what I think are sort of the key areas. Washington State Department of Health certifies 2 types of crisis diversion facilities currently, which are identical in function but referred to by different names: crisis stabilization units and triage facilities. A crisis stabilization unit or triage facility is a short-term facility licensed as a residential treatment facility, which can keep clients for up to 3 days. That's not fully accurate, 3 to 5 days, as I had mentioned, but typically Medicaid will pay for 3 to 5 days. I did want to mention, just because it's been really helpful in a shout out, the Behavioral Health Administrative Services Organization, Ms. Carruthers is a part of that outfit, as well as many others. They actually have a contract with both of our providers that if an individual's insurance does not cover, or for some reason they aren't insured, the providers can invoice the BHASO, so they will not turn the person away because of their insurance. And that support from the BHASO has been fairly consistently used, as I understand that. Again, since we don't pay for their services specifically, I'm not entitled to look at their invoicing and et cetera. But anecdotally, both Compass Health and Pioneer Human Services certainly utilize that resource with our Behavioral Health Administrative Services organization. So thank you, Linda, and others. Yes, ma'am.
Oh, yeah, thanks, Perry. Just a very quick clarification, because we did have a lot of internal discussions early on regarding that. So like I do authorizations, as they come in the door for the substance use disorder side of the house. And so yes, even folks who are not meeting all of our eligibility criteria, with the one exception of being out of region. That was the one area that we determined, if someone is active Medicaid, I'm sorry, I scratch that. If someone is active Medicaid, we generally kick that back, because ultimately their managed care organization should be funding. But all other elements that we usually screen for eligibility, including being out of region, we essentially are paying capacity for the I believe it's for both sides of the Compass as well as Pioneer.
Yep.
And on the 23-hour piece, I just wanted to note, the state healthcare authority has been hosting a whole range of meetings, kind of a work group discussing various elements of the 23-hour crisis. They're having another one this evening at 5 o'clock. So that's Dan Overton and Healthcare Authority are putting those out. So a lot of interesting info in those.
Thanks, Linda. Yes, I have had the opportunity to attend those thus far. They're rulemaking, and they're really going through the very extensive legislative language to establish the parameters, the level of care, how providers would accomplish certain tasks, and so forth. So it really gets down into the details. And actually this document makes reference to that just towards the end. Down here in this sort of lower paragraph, say that, let me just expand this a little bit. The other states, if folks aren't aware, Arizona is one of them. There's another 23-hour crisis relief center being built in Kent, Washington. And so this is sometimes referred to as a living room model, essentially because instead of beds, the facility admit the client to a lazy boy recliner. That's an interesting, use of terms, but to a recliner, using an open layout instead of individual rooms. Other features of the model include procedures to make a client drop off as fast and frictionless as possible for law enforcement. And I think, again, some of the things that we've learned, just in regard to these challenges, there are some differences with a 23-hour crisis relief center, because there is essentially, so long as capacity has not been met, I'm speaking legislative language here, there is a no refusal policy to this level of care. And so, yes, Councilmember Donovan.
So is the less than 24 hours, is that part of how we fund it, that there's, I don't know, is it Medicaid or state funds to operate this? And if it was over 24 hours, we wouldn't get those. What is the, I guess first, what's the operating cost and why is the less than 24 hours?
Right. Great question. One of the things that this does is from a Medicaid standpoint and licensure standpoint, that this makes the facility an outpatient service as opposed to an inpatient service, which speaks volumes, just in regard to funding and so forth. It would be paid for, and this is also in the legislative language for healthcare authority and entities to work with the managed care organizations, Medicaid, and be able to, develop a usable cost basis for operations. We aren't far enough into it to say what does it cost operationally, but this is a multidisciplinary team. I think this is a really interesting concept. Multidisciplinary team that includes a, to be able to care for basic physical needs or basic health. Also a prescriber that is capable of prescribing medication for, withdrawal and or for psychotropic medication for individuals that may be in need of that relative to mental health challenges. And so the staffing model is really about it almost reminds me of an emergency room kind of model that is oriented towards individuals, a brief involvement, stabilization, stay, and then obviously referral. I mean, the case management component is going to be really important. Some individuals aren't going to have any interest in receiving any further services and just simply want to be discharged. There are other individuals that I believe will be open to that. And the discussion at this point in time has been to build this facility out on Division Street in the same, campus as the Crisis Stabilization Center. And most certainly what I'm advocating for is, for example, that they would use the same paperwork that the providers at the Crisis Stabilization Center are using, because it's really all the same information. They're asking the same questions.
The provider will bill Medicaid or the state as an outpatient.
Correct. And if an individual needs to be transferred from the 23-hour crisis relief center, the paperwork is already completed. And literally the transfer is a walk across the parking lot, or in the case of, wheelchair or something else that needs to be used. But I do, similar to Mr. Hilly, at least I think, this is what he was making reference to. I see this as almost a holding place for some individuals, that there's a much greater length of time to work on the admission to the Crisis Stabilization Center if the individual is open to that, and to gather the information and get them in for a longer stay, because that's what's warranted based on their particular symptomology and so forth. Yes, Mr. Hilly.
Yeah, thanks. And I was just going to mention that that concept of having a place to hold somebody till you can figure out what better to do with them. And I wanted to ask Perry, have you been watching? So there's I believe it's Senate Bill 5536, and they are in the rulemaking process right now. I listened in on this the other day, and this is the bill itself is related to mostly diversion for law enforcement. However, it looks like in that bill they were discussing the what were called opioid treatment facilities. Where a person who experienced an overdose, or if law enforcement had engaged but they don't arrest, they could divert to this facility, which once again would be similar, but it would be opioid specific. And I talked to Seattle, the medical director at a Seattle Fire here 3 days ago, and they're jumping on that opportunity where they're going to be converting one of the old, it's called the Morrison Hotel. It was a men's sleep shelter during the night that was dismantled during the pandemic. So they've remodeled it. And the idea is that, if law enforcement picks somebody up either after an overdose, or they reverse it, or they're busted for a couple of pills, they'll just take them over to this facility and they can chill in a 23-hour similar type of facility, lounge chairs. And if that's the day that you want to start MAT treatment, they will be able to offer that in there. And actually, the fire department is even talking about the EMTs would be able to even deliver the Suboxone in the field to transfer to this facility as well. And so that may be another option to look at as we kind of get through this. But I know they're in the rulemaking now, and the last session I heard was what the facility looks like, what the transfer in would be. et cetera, in that idea. And once again, if we can get people, instead of running from us and say that they don't have to go to the hospital, we may be able to change the narrative in our community to say, hey, there's an alternative. You're not going to be stigma. You're not going to be set out in that ED waiting room for hours on end. We can take you to this place for a more specific outreach.
Right. I have not looked at that, Mike. I appreciate that, because I will, continue to follow that and get a little bit more information, because it sounds like a really viable idea.
Yeah,
I
and I'm not
know-
really familiar with the guts of it. It looks like it was some changes from maybe an original bill a couple of years ago about opioid treatment centers, but my sense is that's the spirit of what was going on with that bill.
Right. Interesting. Robust discussion and much appreciated. We are at the top of the hour, just a couple of minutes past. I suspect that Ms. Nixon has been looking at her watch and wondering when I'm going to bring this train to a halt. So I will turn it over to Ms. Nixon for public comment.
Thank you, Perry. Thank you. We do have one attendee today with a hand raised to speak to the committee. Jason, go ahead and speak.
Hey, good afternoon. Hey, good afternoon, gentlemen. Jason DeForest here, local business center. Wanted to touch on a couple things. There was a gentleman talking about a 12-hour hold there. I would caution you guys to be very careful on what you do with folks and how you manage that. Those are civil rights violations that you're talking about on record. And you have to be very careful what you do with folks and not violate their civil rights. I think we have enough of that already going on in the community with healthcare workers and police officers. I think if you look recently, there was a gentleman at the jail that just filed a federal civil rights complaint against a nurse there at the jail. And I believe the county council tried to cover that up or erase that information by having her name stricken from it. These are things that we need to be watching and keeping an eye on. There was more that I wanted to speak to, and I've unfortunately lost my train of thought. I wish I could speak while you guys were speaking, because I could touch on some of those things. Oh, Perry, the vehicle. I saw this morning as I stopped at a stoplight, there was a group of contractors picking up one of the homeless folks to take him to work, and he had his cart with him. And it made me think of you, and I thought, make sure that he's got room in that van or whatever he's using to help these folks so that he can carry those things. They carry everything they have in a cart, and they need somewhere to put that stuff if you're going to take them somewhere, because they can't just leave it sitting on the corner of the street. Somebody else take it. So I want you to think about that while you're working on your van situation there. Also, are there any statistics out of the Public Servant Accountability Office for Whatcom County? And what do they have to say about what's going on and what's actually happening with these folks? Thanks.
All right. Thank you, Jason. And it doesn't look like we have any other hands raised. So that's it for public comment. Thank you.
All right. Well, again, really appreciate the time and honestly the detail of discussion and the expertise that's in the room. If there is nothing further, I will bring this Crisis Stabilization Center Subcommittee meeting to a close.
Thanks, everybody.
Thanks, everyone.